To another episode of Core Insights. We're really excited to talk about a pretty interesting and fun and pretty practical trial that we did with the QC data. And I would like to introduce one of my colleagues, Shervin Etemad. He is an intern, plastic surgery resident, I should say, at USC. He worked with me at Vanderbilt a couple of years ago and did the study where we really wanted to look at using the QC data, look to see if fixation is necessary in rectus repairs, or specifically retromuscular repairs. And part of the reasoning for this was a lot of you do robotic retromuscular repairs don't use a lot of fixation. So we kind of thought, hey, can we also apply that to the open population and see if it really holds true? It's a pretty confined space. Maybe don't need as much fixation that we thought. So what our agenda tonight is going to be is Shervin is going to present a study that we did a couple of years ago, and it got accepted to the PRS, Plastics and Reconstructive Surgery Journal. And then actually we did something kind of cool. We actually put this out on their Facebook page and had kind of a Facebook Live discussion, and Shervin's going to talk a little bit about that. Then we got a couple of discussants, and then Ajita is going to talk about a follow-up trial that the clinic is doing, looking at also this specific question. So welcome everybody. It should be a fun discussion. And Shervin, if you want to go ahead and start, let's kick it off.
Sure thing. I'm just going to go ahead and share my screen. Give me 1 second. And desktop too. All right, can you all see that screen okay?
Good, yeah, we got it, perfect.
Awesome. Well, thank you all for having me, Dr. Paulus, Dr. Rosen. It's great to be here with you to share this work. My name is Shervin Etemad. I'm currently a resident in plastic and reconstructive surgery at the University of Southern California. Thanks to the QC team, as well as the ACHQC registry team that I worked on this project with as a medical student at Vanderbilt. And we'll go ahead. Okay, I have no disclosures. As we're all well aware, ventral hernia repair is one of the most common operations performed in the US with significant associated costs. Mesh use is a well-accepted technique to distribute the tension over the repair area and has been shown to result in decreased hernia recurrence. Among placement locations, the retromuscular compartment provides an ideal space for durability, minimized wound events, and protection from intra-abdominal viscera. So mesh fixation in general serves several purposes, aiding in the distribution of tensile forces and offloading the fascia, thought to be specifically important in the early stages of wound healing, aiding in mesh tissue approximation, as well as limiting mesh migration, which is thought to be one of the driving forces of hernia recurrence. Mesh fixation has most commonly been achieved through mechanical approaches that rely on sutures, tacks, or staples. Given concerns of nerve entrapment contributing to postoperative pain in mechanical fixation cases, some surgeons have shifted towards a non-mechanical fixation relying on either fixation-free approach, just placement of mesh in the retrorectus space with no adjuncts, or the use of adjuncts such as adhesives or self-adhering mesh. The primary concern with this shift has been the effects on hernia recurrence, specifically early recurrence in the early stages of wound healing and fibrosis, which are thought to be critical in stabilizing mesh. So the knowledge gap that we aimed to address in this study is whether mechanical fixation can be abandoned in select clinical scenarios of retromuscular ventral hernia repair in favor of a fixation-free mesh placement. Our aim was to compare outcomes following mechanical in retromuscular ventral hernia repair following mechanical versus fixation-free mesh placement in open cases less than 15 centimeters. To investigate this question, we used data from the ACHQC, which at the time of our study had 39,000 patients and 312 surgeons. And I just took a look last night, has notably nearly doubled in the amount of patients in the registry. We focused our study population on adults undergoing open elective retromuscular ventral hernia repair with placement of permanent synthetic mesh in a class 1 wound, and excluded cases of peristomal hernia repair, repairs that utilize self-fixating mesh or adhesives, and those greater than 15 centimeters. 15 centimeters was decided on as larger defects may warrant a mechanical approach of fixation, given the propensity for early recurrence and higher tensile forces placed on the mesh. We compared patients undergoing mechanical fixation to those undergoing fixation-free placement with no self-fixating mesh or any adhesive adjuncts. Our primary outcome was 30-day composite hernia recurrence. So that's recurrence based on surgeon evaluation, radiographic study, or patient-reported occurrence using the ventral hernia recurrence inventory. Our secondary outcomes were also 30-day outcomes of hospital length of stay, readmission, reoperation, wound events, patient-reported pain, as well as patient-reported abdominal wall function. We also evaluated 1 and 2 year composite recurrence and 3-year cumulative composite recurrence, and used a propensity score matching algorithm to achieve comparison groups. So in terms of our population, we performed a 3-to-1 match on 897 patients undergoing mechanical fixation and 299 patients undergoing fixation-free mesh placement. To the right here is a plot of standardized mean differences for each covariate that was part of the model. So our propensity score took into consideration the covariates that are listed here. And a standardized mean difference is the degree to which a patient characteristic differs between the 2 study groups, with the common convention being that a difference less than 0.1 represents an acceptable balance of covariate to indicate successful matching, as we can see in the blue triangles. So in terms of our results, here's our table 1 to the left, and I've just kind of highlighted the different characteristics, patient demographic and operative characteristics that were significantly different between our 2 populations when we entered our analysis. So patients in the mechanical fixation group were more likely to have received preoperative bowel prep on chlorhexidine scrubs at home and have undergone a longer operation, whereas patients in the fixation-free group were more likely to have a larger mesh size placed and myofascial release performed. So our primary outcome of 30-day recurrence, with regards to that, there was no difference between the 2 groups. Patients undergoing mechanical fixation did have slightly longer length of stay. And among the outcomes listed here in terms of wound events, readmissions, and reoperation, there were no differences noted. We did have 100% data reporting between these 2 groups, and that's just something I'm going to highlight as we go along here, because given our reliance on patient-reported outcomes for some of our outcomes, of course, it's a challenge to have 100% data reporting, and that's just something that's a continuing challenge that I wanted to be transparent about. So onto our patient-reported outcomes. This is at 30 days of pain and abdominal wall function. We had 37 and 44% response rates for the 2 groups respectively. The groups were similar in terms of their baseline scores, with significant differences at 30 days. So patients undergoing mechanical fixation were more likely to report significant pain at 30 days and worse abdominal wall function. And we also ran an analysis on longer term recurrence, which didn't show any difference, however, in the context of much more limited patient response rates, which I'll comment on as well. So what are the limitations of these conclusions? Of course, the registry is not representative of all surgeons. This is a retrospective study. The propensity score can only account for observed variables, which I listed in the standardized mean differences plot. And it's possible that the outcome is contingent on patient or surgeon factors that aren't captured in the models. For example, preoperative opioid use might be something that would be significant in considering rates of pain at 30 days that we didn't necessarily have that level of granularity for this specific study. So in terms of a discussion, kind of a few points that came up. So differences between our populations. Patients who underwent mechanical fixation were more likely to have a pre-op bowel scrub or a pre-op scrub and a bowel prep, indicating possible anticipation for a more extensive dissection. Fixation as a driver of increased operative time is clear. We do interpret the increased mesh size as an increased mesh size in the fixation-free group as an increased reliance on mesh overlap for stabilization from tissue ingrowth. In addition, in the absence of mechanical fixation, it's important for the mesh to lie flat, which may be a reason for a larger dissection and associated mesh size. There was an increased rate of myofascial release in the fixation-free group, potentially attributable to the increased use of releases to allow for more generous overlap and minimal buckling of the mesh prosthesis. Transfascial suture fixation, of course, is, it's been shown to be a driver of pain, but to what extent, as we consider different levels of dissection? These are just questions that, we can address as well in our discussion. But to what extent, as we consider different levels of dissection, as you move laterally where nerves may be larger and there's different chances of suture entrapment, depending on where specifically you are in the abdominal wall. Our study did exclude fibrin glue and self-fixating mesh. We wanted to focus on solely fixation-free placement and really isolate that as a variable without any confounders. But of course, when you think of the role of fibrin glue, which is used commonly, self-fixating meshes, what about other fixation adjuncts such as mesh sutures, tack fixations, or different new products that you all may be more aware of than I am at this point? What role do those have in thinking about a fixation algorithm? In addition, challenge of long-term recurrence. So for long-term recurrence, of course, we're limited as, relying on a patient-reported outcome for how many patients are reporting. But, the sense that I've gotten in sharing some of this work is that longer-term recurrence is a significant concern, to both patients and surgeons. And of course, we focused on short-term recurrence, given that as a technical concern of a fixation-free placement during kind of that early stage of wound healing and fibrosis. But how can we, look at long-term recurrence in this population in a critical way? And lastly, what about the cost effectiveness of the different fixation approaches? Whether that's the cost effectiveness of the medical device itself, or the cost savings of, in terms of reduced hospital length of stay or reductions in complications that may be associated with different fixation approaches. So in conclusion, fixation-free mesh placement, we concluded is an acceptable alternative to mechanical fixation in select cases of open retromuscular ventral hernia repair of less than 15 centimeters in a clean wound in adults with our exclusion criteria that I outlined earlier. We didn't see any difference in early recurrence, and this was 100% data reporting for that. There was a shorter length of stay among the fixation-free placement cases, 100% data reporting for that. Less pain and improved abdominal wall function. Of course, we're limited. We were more limited in terms of that conclusion in our percentage of patients reporting, but based on our discussions and analysis, we were comfortable making that conclusion. Of course, the longer term conclusions still, I think, would be supported by a more robust response rate. And just wanted to thank, of course, Dr. Paulus, Dr. Pierce, the Quality Collaborative, our statistics team, Li-Ching Huang, Tom Stewart, Sharon Phillips, my colleague Steven Schneeberger, who I was able to work on some of this with, and Vanderbilt for giving us the protected time as medical students to do it. And yeah, I look forward to any kind of discussion and questions. And before I go there, I would just like to maybe share a brief, just briefly, this is what we did on Facebook, which was a new forum to me. But this was sorry, I wish I can highlight this and not our faces, but we have 112 comments here through this Facebook PRS Journal Club. And these are folks from all over the world who were able to comment, ask questions that we were able to address. And some of these conversations even kind of took off in terms of personal kind of one-on-one message threads. So, as we explore kind of different ways to share our work, stimulate discussion, this is certainly an exciting new forum. Thank you.
That's awesome. Thanks, Shervin. Great presentation, and thanks for highlighting that PRS Facebook thing. I thought that was really, really cool. So yeah, I mean, really compelling results there. This study certainly, was a motivator to change my practice, and I think a lot of others have also adopted a lot of fixation-free techniques based on this. So what we'd like to do is go ahead and invite our discussants while this study is kind of fresh in our minds. We have Dr. Arielle Perez from UNC Chapel Hill and Dr. David Krpata from the clinic as well, who are going to discuss the study. Then we'll move on to an adjunct presentation by Dr. Prabhu. So Arielle and David, you guys want to unmute yourself?
Sure. First? Yeah, sure. I guess I can go first. Shervin, great presentation. I think this is a very laudable study, looking at the analysis of figuring out, do we really even need to fixate mesh and do our transfascial sutures, especially with our big open repairs? Is it something that's even necessary? And their data is actually fairly compelling, looking at the fact that it seems like the recurrence rate, 30-day recurrence rate, really is pretty much exactly the same. Most of the SSIs, SSOPIs, pretty much all exactly the same. And really the big difference is the length of stay, and as well you have increased pain and worse function. One of the things that I kind of noticed is, and you had kind of mentioned in the discussion, is that the size of the mesh for the fixation-free patient seems to be a bit larger, about 900 centimeters squared versus that in the patients with mechanical fixation. I'm wondering, is the reason for not using mechanical fixation because you have to do more overlap, you have to do a bigger dissection? Is that something that you would kind of support in terms of, if you want to try and avoid fixation, should we be trying to get more overlap? Should we be doing kind of a further dissection rather than just staying with the retrorectus repair? Should we be doing a posterior component release so that we can get further overlap?
Shervin, you want to take a stab at that?
Yeah, absolutely. I think, as one of the things that your comment makes me think about is, when you think about the impact of the necessity for, in the fixation-free cases, we're relying on, wound healing, tissue ingrowth, and fibrosis to provide that offloading of the tension on the mesh and the fascia specifically. And how much of that is needed, is in terms of what amount of overlap can translate to the security you're getting from fixation. So I do think that, it may make sense to, if you're really worried about the early recurrences, potentially a posterior component separation and relying on greater overlap. I'm not sure clinically how you guys think about what risks there are to that, increased dissection and component separation, if you're thinking about that. But, I think I struggled with it too, because it's, we're kind of thinking, well, is that enough? Is that going to be enough, tissue ingrowth and fibrosis to stabilize the mesh? How much more will you need in terms of the biomechanics of it? But I do think it would stand to reason that a more extensive dissection, would be appropriate, especially in the early stages of a fixation-free placement, as we learn more about the data.
Yeah, and I think it's interesting if you look at the time frame of the data from the QC. I think it ends at 2017. So this was definitely in the transition period where a lot of people were moving towards fixation-free techniques. So I think, honestly, people just freaked out that, wow, we better get a wider dissection, just in case something happens as some kind of measure of security. Certainly I did. I probably did more dissection than necessary. But I think as we gain familiarity with it, and then if you also kind of think back, many of us have gone in within a few days after placing Retro-Muscular, even heavyweight polypropylene, and it's, it can be pretty well fixated in a couple of days, pretty set, that's not going to move around. So I think based on that observation, and also with the more familiarity with the technique, I'm not sure I would say we would, change our technique where we would go ahead and do a posterior components just for the sake of the additional overlap to prevent an early technical failure at this point. So I think it's really evolved.
I'll go next, I guess. We can go back and forth, Arielle, if that's okay. I only have 11 questions for Shervin. So, first I want to point out that Facebook thing was pretty cool. It looked like it was a family reunion, though, for Ben. I think it was mostly his extended aunts and stuff that were writing stuff. Really nice job, though. So my first question for you is just.
David is my cousin from Chicago. They were all there.
Kind of design related. I want to kind of go back to when you guys first kind of thought about this study. And my specific question is, in your manuscript, you quoted that nerve entrapment or localized ischemia was one of those potential reasons for causing pain. So I'm curious as to why you guys decided from the beginning to exclude those adjunct groups in terms of the glue versus the self-fixating meshes, because those should be considered, non-ischemic, non-piercing through any nerves, so or an entire group in themselves. So what was your decision there to exclude those?
Yeah, absolutely. I think the decision there was, thinking about our primary outcome being the 30-day recurrence, and really that as a driving force for folks deciding whether or not to adopt this technique. We thought that we would like to isolate the fixation-free mesh placement as a single variable, and of course, subsequent analyses, are definitely warranted to include those adjuncts and look at the effects of those. But we really wanted to make a statement about fixation-free placement alone and what impact and role that might have, and of course build on that, looking at the different adjuncts.
Okay, David, one down, 10 to go.
I got more. So another thing about design and stuff. So obviously, there's some challenges because, as you mentioned in your manuscript and everything, you can't correct for like ERAS and things like that in terms of, surgeon practice. But did you consider using the surgeon themselves as one of the covariates within your logistic regression, and then propensity matching to see if you could potentially correct for that? Obviously, there's some downsides to that if you could correct in one direction, but then impact patient selection in another direction by the surgeon. So any thoughts on using surgeons in this sort of manner when you do propensity matching?
Yeah, I think that's a really great idea. It was it came up in our discussions as we were thinking of the design, of course, because we were anticipating the limitations of our analysis and our model. I don't know if the challenge at that time, this is almost 4 years ago now, would have been, do we have enough numbers to power a study in terms of using a surgeon as one of the covariates? And if we were to do that, do we limit our the number of patients? And we had 897 in the mechanical group and 299 in the fixation-free group. And we ran a few of the early iterations of it with different covariates, and really wanted to optimize, of course, relevant covariates, but also make sure we had robust comparison groups. But I think that as we have more data, and as you all are doing more of these cases, and we can certainly consider that as a covariate as well.
Yeah, I think you're right on that in terms of we would limit certainly the numbers. So it would be interesting to potentially take your primary outcome of interest and whether or not it's worth it to do some sort of power calculation beforehand to see if you would have enough to that you can then use it as a covariate. I got more questions, but Arielle, do you want to throw one in there too?
Yeah, no. So I was wondering, in terms of kind of the mesh, you'd ruled out looking at the self-fixating mesh, but did you notice any difference in terms of the type of permanent synthetic, if it was macroporous or microporous?
My understanding is that at the time of this analysis, we didn't have that specific granularity to our information. I'm pulling up our table 1. In terms of, we of course, we limited to permanent synthetics. That's not going to be there. In an earlier analysis, we didn't limit it to permanent synthetic meshes, but the overwhelming majority of the cases were permanent synthetic. And we thought that, given that, we might as well limit it at this point. And again, just, try to minimize the confounding variables. But I don't know, Dr. Paulus, if at this point, is that data that's captured on your guys' end in the registry, and is that something that maybe we can include in the future?
Yeah, it's certainly going to be a mix of different weights of polypropylene. We didn't look specifically at the distribution of those individual weights. So yeah, Arielle, good question. It's certainly something that we could take a peek at.
And I'm seeing a question in the chat here. Early recurrence is such a rare event. Why not just have pain or quality of life be the primary endpoint? Definitely a great point. I think, everyone has the things that drive their decision making. When we were thinking of this study, we were thinking that, early recurrence and that initial mesh stabilization that, transfascial suture fixation or some sort of type of fixation adjunct would allow for, removing that may increase the risk for, early slippage and recurrence, which is why we called that our primary endpoint. But of course, our analysis wasn't any different, whether we called that our primary endpoint or pain or quality of life. And, that was just kind of how we decided to structure our results and our focus. But I think good question.
Yeah, one follow-up comment to that exactly. I think the thing that freaks people out the most about moving to this technique, especially if you're primarily a fixation type person, is just that fear of something's going to move around in the first few weeks and defeat your repair early. So yeah, Shervin mentioned that's why we selected that. I'll tell you, those of us who trained a lot in retromuscular repairs, one of the tenets we kind of ascribe to is the fact that you're fixating mesh. You look at a cross section of the abdominal wall with the mesh in place, you're fixating the mesh more centrally and then fixating to the abdominal wall more laterally. And then when you tie everything together and cinch down the transfascial fixations, you redistribute the tension on the mesh and take it off your primary fascial closure. It's kind of how we all learned that. Whether or not that's as important as we think, may be up to question, or maybe things just remodel so quickly that's not as big of a point as we thought. That was my biggest fear, honestly. So,
hey, Shervin and Ben, can I ask you guys a quick question about kind of your trial design and how you set this up? And I think maybe Shervin, let me just start with you. So when you decided to do this, there must have been in your mind, you thought, well, it probably doesn't matter if we don't put sutures in there for early recurrence, but man, those sutures hurt a lot. And they clearly have some downside to it. I'm sure that kind of was somewhat of the interest in getting this going. So I think one of the things we should always kind of discuss, particularly for using the ACHQC, is what is the best method to interpret the data? Because one of the things that you run the risk of as our database gets larger and larger and larger is that we start to find small differences that are statistically significant, but are potentially clinically not so different. And I think that with the onslaught of large database reviews, there is a lot of decisions made in surgery kind of based on that fallacy. And so I'm just curious, when you set this up, I think one of the best ways to set this up is before you look at the data, say, okay, this is what we think a minimal clinical important difference will be for pain. This is a clinically important difference for recurrence and for, abdominal wall function. And then figure out how many patients or whether you've reached that power, or even if there's a statistically significant difference, couch it back on maybe this isn't as clinically relevant. Because if I kind of twisted your analysis just a little bit to kind of fit my bias, which is somewhat changing, to be fair, I would say, well, reality is there wasn't that much difference in pain. It was 2 points. It was statistically significant, but it was 2 points. The early recurrence is the same. Long-term, we don't really know. And length of stay is kind of all over the place. So if there's really no difference between suturing and not suturing, why not just put the sutures in?
Yeah, no, I think that's a really good point. And, I think that's, even when you look at our length of stay being, 4 versus 3 as a median number of days and with fair amount of overlap in the interquartile range, drawing conclusions on statistically significant things that, may not be clinically relevant. I do think when you look at the 30-day recurrence though, and the fact that there wasn't a difference between the groups, for me, that holds more weight than, making your call on the length of stay difference alone or the pain difference alone. We're also looking at, these devices have costs associated with them. Operative time was a difference, in terms of thinking about, somebody's practice and what you're able to accomplish in a given amount of time for the most number of patients possible. Those are things that, aren't necessarily reliant on the difference in the, in the numbers, but just binary, was it greater than 2 hours or not? But no, I do think that it's a really relevant point about how we draw these conclusions. And I'm just starting to appreciate that more on my end, going from looking at these studies and just saying, okay, there's a statistical difference. I remember we would get these analyses and the reports, and I would get excited about, there's a difference between the groups, and then we get another report, and then that difference is gone because, our propensity score has changed. And then, if that alone is enough to, change our conclusions, then how durable and conserved will our conclusions be, in the clinical arena? So that's a long-winded way of saying that I'm still, I don't know exactly, how to dice that out. But I do think that it needs to be addressed, as we start thinking about.
I think it just shows that Ben's very good at manipulating the data to his bias. That's what MPH stands for.
I was going to say,
David,
Shervin, you're
get back to
being
work.
too nice. You could call out Rose's BS like after a certain amount of exposure to. I'm going to call him out right now. So while I'm calling him out, Shervin, can you do me a favor? Can you pull up your slides again and show us the propensity score mass results for Hercules at 30 days while you're pulling that up? Yeah. Okay, so while he's pulling that up, Mike, yeah, you're right. As you get larger and larger in data sets, NSQIP actually falls. This happens all the time in NSQIP studies where you'll see this tiny, tiny little difference that shows up as statistically significant. And then you get these grandiose paper titles. They get published in JAMA Surgeon, all these kind of things, but essentially they're kind of meaningless. That's a critical point. So if you look at what Shervin's pulling up here, so looking at patient-reported outcomes, the fixation-free versus the mechanical fixation for PROs or abdominal wall function. So at baseline, Hercules was the same. And then at 30 days, we actually see a pretty reasonable difference there. Almost, it looks like 13 points in favor of fixation-free, 60 to 47. And there's the interquartile range there. So what we didn't know at the time, Mike, was the minimum clinical important difference for Hercules at the time of this study. When I transitioned from Vandy to Ohio State, we did the study, and the MCID was about 15. So this is just shy of the MCID by a couple of points. So, it's close, but certainly, within that range there. Points well taken. But, my conclusion for this, it's so funny. Rose and I can have the exact same data set in front of us, and we'll always have the complete opposite conclusion. It's actually kind of fun. So I would actually say that even if you assume that everything is equipoise, they're all the same, every outcome we looked at, because fixating has a little bit more risk associated with it than not fixating, and that is bleeds, the revered needle, kind of slips out of your view for a second, maybe going somewhere that you don't like, you lose sleep for a few days. That's an inherently more risky move than not fixating. I would say err on the side of no fixation.
So 2 more follow-up questions on that in terms of the outcomes and the PROMIS score. So, it's pretty easy, I think, for people to look at a VAS score and at least the smiley faces and say going from this to this means that you're going from tears to no tears or something. But really, what does like going from 46 to 44 actually mean? Like, is that really painful? I mean, what is that?
Yeah, I think that definitely can that highlights Dr. Rosen's point regarding thinking about minimal clinically important distinctions and differences that are truly clinically significant versus differences that we may pick up on our analysis, which may be clinically significant in the context of a stronger more powered study. We did have 37% of patients in the mechanical fixation group and 44% in the fixation free group reporting. So these are all patients that are either received these surveys in follow-up clinic visits within 30 days or are called by phone. So one of the things that we thought about was, is there a difference in the people who are reporting versus not reporting? Is there a difference in the patients who actually do we have a bias in terms of who we get in the early stages actually report their patient reported outcomes? But yeah, I do agree that maybe it may be a softer call regarding 44 versus 46 in the pain group. Of course, our abdominal wall function group is a larger difference in magnitude while also clinically statistically significant. So I think that's a fair point.
Good, good. I'll tell you what. Hey, David, I'm gonna cut you off here, just in a matter of time. So yeah, you can stop at 3. You'll be fine. You'll be all right. You'll be okay.
Thank you.
I think that was 4 actually. Arielle, do you have any other wrap up questions before we get Dr. Prabhu on?
Yeah, no, I think in terms of, it seems like you've adopted this practice of no fixation. Is there anything kind of, as you've started doing more and more of this, anything that you've actually changed in terms of your dissection or mesh placement, or even post-operative care since you've moved away from fixation?
Yeah, so the mesh has to lay really flat. There can't be any buckling. I try to make sure on the edges that there's not even any curling up towards the extent of the dissection. I think drains are quite important with this, just to kind of minimize fluid from creeping up in between the mesh and the muscle. So I drain all of these. I use the same criteria for removal, and that is really I just if they're retromuscular, class 1 is take them out before they go home, basically.
Wait, do you
so
mean
really those are the main things that I use?
You don't put drains in
What's
patients that you put fixation in?
I don't put, no, I drain everybody. Yep, drain everybody.
Got it.
So, great. All right, Dr. Prabhu. Yep, we got you.
All right. All righty. Is that in slideshow presentation? I can't tell from my screen
It's
here.
not just yet. While you get it up there, I'll kind of introduce this. So one of the cool things about the QC, and I think this is one of the most powerful things that we're about to show you here, is we've just discussed kind of a classical study done using a data set, retrospective review of prospectively collected registry data. But now what we're going to do is take this in a significant step further, and our colleagues at the clinic have really taken this to another level in terms of embedding randomized controlled trials within the QC. So I think the really cool part of this is we've taken collectively the retrospective data and now used that to figure out, hey, how can we kind of answer the question one step further using a randomized controlled trial? So Dr. Prabhu is going to give us an update on the status of this trial. Ajita.
All right, thank you for letting us present this today. So we're going to present the design of our trial that is a prospective look at, I think, some similar themes to what you had before. So I won't spend too much time on the kind of origin of this trial, other than to say the question is heavily based upon some of the same themes and questions that you asked in your own study. And the main things that we think about are that when we all trained, we were taught to standardly put these transfascial sutures in, and that was just a known thing, as you mentioned. And then also, as you mentioned, we don't really know for sure what their contributions are to short-term and or long-term pain associated specifically with those mesh fixation sutures or other devices. They're not really well studied at all in terms of long-term hernia recurrence. And so all of those things drove us to put together a prospective look at this. So the aims of our study are fivefold. The primary outcome that we want to look at is hernia recurrence rates between the fixation and no fixation groups. And we'll talk a little bit about how we've defined our primary outcome, but the outcome time frame is at 1 year. So we can get a little bit longer term look at an outcome. Specifically, we picked hernia recurrence rates because of some of the reasons that we mentioned before. So length of stay can be a little bit nebulous, and particularly when we have patients traveling to see us, as many of these do. And there are all kinds of other reasons that are confounding variables that may contribute to length of stay. So we specifically stayed away from that and wanted to look at the actual efficacy of fixation versus non-fixation. And we'll talk a little bit more about that methodology in a minute. We also wanted to know for aims 2 and 3, differences between pain in the fixation group versus the non-fixation group in the immediate postoperative period. So we're doing that looking at the validated NRS 11 survey, and then pain between groups at 30 days using the PROMIS 3A survey. The fourth aim is to look at the differences in terms of in-hospital oral and IV narcotic usage between the groups. So that gives us not just the measure of pain, but also a surrogate measure of pain. So 2 different avenues for looking at the kind of effect on their pain postoperatively. And then finally, we are going to look at length of stay between the groups, but didn't make it our primary outcome, as mentioned. And that will be gotten from our EMR and then also from the Quality Collaborative, obviously. And this is a registry-based trial, which is an important thing for us because most of the PROs and that type of thing that we are collecting are already commonly collected by us. So there's not a whole lot extra here. Our hypothesis in putting this together was that hernia recurrence rates for patients receiving no transfascial fixation would be non-inferior to those receiving transfascial fixation at 1 year, with the concept being essentially that no fixation does not have to be better in terms of recurrences at 1 year, but it has to perform at least the same in terms of recurrences for any of the other outcomes to really be very clinically relevant. For our study design, this is a single-blinded, actually it's a double-blinded, that's a typo, registry-based prospective randomized control trial. Specifically, what we mean by double-blinded is that we will have blinded assessors reviewing the CT scans and the people getting and that's for recurrence. And then as far as for our pain data, our researchers that are getting the pain data are also going to be blinded to the intervention. This is a non-inferiority design for the reason that I mentioned. And the 2 groups are specifically mesh fixation versus no fixation, and these are for open retromuscular repairs. For inclusion criteria, obviously adults, elective open repair through a midline approach. And importantly, we have to determine that fascial approximation can be achieved during the conduct of the case. And the hernia defect width for this, we selected 20 centimeters or less because I think we have a good indication from looking at our own data that in our group, we are most commonly able to close the fascia to the midline in defects of this size. Beyond that, we didn't venture out, I think, because we start to get into the territory of potentially bridged operations, which I think is a little bit of a different consideration. I do want to point out that while we said that these are midline hernia defects, we are careful to make sure that we've included, and this may, be a little bit like fingernails on a chalkboard to some people. When I trained, if we had a subxiphoidal or a suprapubic hernia, there was bony fixation that was an expected part of that case. To be clear, for us, all comers are candidates, including M1 subxiphoidal and M5 suprapubic hernias. And you can see that, some examples of pictures over to the right side of the screen here, that these hernias go all the way up. And the bottom one, this is a lady who's got a recurrent hernia down low, and you can see her bladder and her pelvis there. So all of these comers are candidates for the trial. And I think it's important to note that, when we're talking about putting no fixation, this is a pretty big shift from how many of us who are doing this study were trained to do this operation. So there is some amount of kind of going out on the ledge with this, but I think it's also important to say that we have the potential to introduce a significant amount of selection bias if we avoid subxiphoidal and suprapubic hernias. So we wanted to make sure that all of these are equally represented to the best of our ability, and that they're not screened out ahead of time for fear of mesh shifting. We wanted to really ask the question and answer the question. And so, to that end, I want to show you an example of somebody that I may not be super proud of this, but I might have consented and randomized this patient. And as you can see, he's got a pretty significant, he's had a pretty significant trauma in his life. This is a young patient, and I'll just show you his CT scan. So that's it. And, I would just say we are trying not to bias ourselves by looking at a hernia up front on the CT scan and just saying, oh, this can't be a candidate. This guy had what I thought was a hernia of 20 centimeters or less in width. And I had a reasonable idea in my head that he would have fascial approximation. So we did, and we consented him and enrolled him in the trial, and he was randomized at the time of surgery. And so here you can see, from this, you might get the idea of what arm this patient was in, but I'll show you why that's not true in just 1 second. So as far as exclusion criteria go, greater than a 20 centimeter defect measured intraoperatively, non-midline or minimally invasive approaches, bridged repairs. So here we've got a picture of, somebody whose fascia would not come together, and you can see that I've sutured the edges of the fascia to the mesh here in the midline. So this person would not be a candidate for our trial. Mesh in a non-retromuscular position or peristomal hernias, which, as we all know, are kind of their own separate beast. As far as the procedure goes, in surgery, there are a couple of things that are important technical aspects here. So we do a retromuscular dissection, and we complete that entire dissection, and we select a mesh as we are closing the posterior rectus sheath, planning for wide overlap in every case. So the specific reason that we randomize after the retromuscular dissection is complete and after the selection of mesh is to keep from biasing ourselves, because we don't want somebody to select a 30 by 30 centimeter piece of mesh, get scared, and then not choose to randomize for whatever reason. If they get, no fixation, now they're suddenly deciding that they're going to put in a 50 by 50. So we wanted to try to avoid that kind of variability in the technical aspects of the operation. So for that reason, retromuscular dissection is complete, mesh is already selected, and we've committed to the size, and we're ready to go before we ever randomize the patient. And I think that does also, by the way, kind of harken back to Ben, what you and Shervin were saying about, perhaps we're doing a bigger dissection for all of these cases, because we know that there's a chance that these patients will not get fixation for their mesh. For those who are randomized to fixation, they get typically 8 transfascial sutures. So usually it's 1 at 12 o'clock, 1 at 6 o'clock, and then 3 out to either side. Additional fixation can be added at the surgeon's discretion. And there's no prescribed way as far as the transfascial sutures at 12 o'clock and 6 o'clock go. So that could include bony or ligamentous fixation there. As far as the no fixation arm, importantly, so the mesh is placed into the retromuscular space when we're ready to do that part of the case. There is no fixation whatsoever of any sort, including adhesives, including any kind of secret fixation. It's just put in there. And then importantly, there are sham stab incisions for those without fixation. So as far as that guy that I showed you in that picture before, I'll tell you in a year or two what he got. But, the fixation part, and by the way, this is a throwback picture. So does anybody know where I got this from? I know one person does. I didn't actually have a true photograph of transfascial suture fixation. So
I don't know where you got it from, but it's beautiful.
whoop. 2011 called, they want their mesh fixation back. So this is Mike's approach to hernia repair, which hasn't really changed much since 2011. His pictures pretty much look the same. This is my approach to mesh fixation these days. So I don't like to put anything in. That's just my bias, but we're going to see where we end up at the end of this trial. I do want to focus for 1 second about hernia recurrence and how we interpret that and how we define it. So we have actually had so many conversations of late as we kind of continue to embark on this trail of putting together these big randomized control trials. We start to understand it's not just about your primary outcome, but it's about how you define that thing and how you interpret it once you get that. And so for us, there's been a fair amount of discussion within our group, not just with this study, but other studies as well, about how we define a recurrence. So for instance, if somebody comes in response to their ventral hernia recurrence index as saying that they have a bulge, do we consider that as a recurrence or do we not? So, and then if we have a physical exam and or a CT, how do we interpret those things? So as a group, we kind of sat and went through this multiple times and came up with the idea that if they have a ventral hernia recurrence index that's positive for a bulge alone, without any other kind of outcome, so no surgeon physical exam, no CT scan, then that bulge alone will be counted for the purposes of this trial as a hernia recurrence. If they have a physical exam in the office with a surgeon and or a CT, the findings of either of those will trump the findings on the ventral hernia recurrence index. So that is how we are defining ventral hernia recurrence for the purposes of this trial. And I think that it is important that we state that up front so that we're not getting the data and then on the back end trying to do some shenanigans with it to interpret who had a recurrence and who didn't. As far as power goes, we essentially powered this to detect a 10% difference in recurrence. And that again was decided as a group just upon our discussion of what do we think is a minimally important clinical difference here. And so we thought, you know, beyond a difference of 10% in recurrence rates, I don't think any of us would be willing to do non-fixation if there's a greater than 10% difference in recurrence rates. In order to power that, we calculated a sample size of 135 patients per arm with 20% loss to follow-up, which puts us at a total goal of about 325 patients. This is our current status. So we've consented 316 patients and 210 are enrolled and operated. And then as you can see, we're on the path to our complete 30-day follow-up and have some ways to go to get our 1-year follow-up. And this is put together by Katie, who's our research fellow. So thank you for sharing this with us. But this is the trajectory of our trial enrollment, just to show that, you know, once we get going, we've actually been able to fairly quickly enroll for this trial. And this is month over month. And you can see the curve here, which is the cumulative amount of enrollment in the trial. And then down here, the little blue bars you can see are reflective of COVID. So there were months where, you know, we had to shut down for a little while. And so weren't able to consent as much during those times, but all the other months where we were up and running with our elective surgery, things are pretty good and pretty consistent with our trial enrollment. So we're very excited to be this far along the trail and we'll be interested to see what we find. And I'll be happy to take any questions now.
Yeah, Ajita, that's awesome. And it's going to be an incredible trial. And I think it's probably going to be one of the most highly impactful trials that's going to impact a lot of people's practice. Yeah, I just got a couple questions for you. So I know there was some discussion about should you necessarily exclude the off midline hernias. You mentioned you want to have kind of a pretty wide gamut of hernias, including the M1s, the M5s. Why exclude the off midlines here? Do you think it's kind of too different of a beast here, or what was the thought process behind that?
Yeah, I mean, I think for me personally, the flank hernias and lumbar hernias and that type of thing are truly a very different beast, primarily because, as we all know, I think they often suffer from a paucity of soft tissue in the surrounding areas, and there's limitations of kind of the bony prominences there. So you're limited a bit by the ASIS and the costal margin. And I think for, many of us who do this a lot, we will get into a flank hernia and see that there is nowhere to fixate the mesh, and we might be doing bony anchor fixation and that type of thing. And so I think that pathology for hernia disease might be significantly different than a midline hernia. So for me, at least, and I mean, you guys feel free to jump in if you have anything to add there, but that's my reason for not wanting to include the flanks.
Well, Ben, I might just tag on to one thing what Ajita said. I think one of the other big issues with flank hernias is there's often a denervation bulge associated with those, and kind of trying to get to the to the answer of whether fixation causes recurrence when you're using the bulge question. It's very, very complicated. So just to be clear, it has to be approached through a midline incision. If you kind of have an old stomacyte hernia that's just at the linea laminaris, we'll actually include those, but we're just not including the true flanks where we're approaching them through a flank incision, because as Ajita said, it's just, I think maybe that's a future study to wonder, do you need fixation in those too? But it's just such a different disease with a different outcome that I think it would just cloud what we're trying to get at, which is just, which is what Shervin and you did, which is that data, hold up in a randomized trial.
I mean, I think that's a good point. And I also think that from some of these flank and lumbar hernias, particularly if the hernia is large and we're approaching it from a flank incision, we might be doing kind of a reverse TAR per se to go towards the midline. And in doing that, we are, I think, more likely to denervate the abdominal wall and get this kind of bulging that we don't know how to then interpret. So I think that disease process in general. So if we kind of started to do the same thing there that we're doing with our midlines, making these huge hernia or huge retromuscular dissections, I think the cost of that is potentially different.
The one other thing I'd add, and I think this is more of just a philosophical thing about doing these trials, is I think it's important to point out that when we started this, we were very anxious about not putting sutures. I mean, this was our practice. We thought it mattered. I thought it was very important. So, the M1 and M5 was a big discussion. Then you start to kind of put on flanks, just kind of only that I did in 2011 that way. I did in 2007 that way, and I'll do it in 2022 that way. But I think that there is a certain, I think everybody on this call who kind of wants to get involved in some of these trials, which I hope every month more people want to get involved in these trials, but there is a certain kind of quantum leap of taking away your ability to use what you think is your own surgical judgment to then randomize people. And until you actually do that, you never fully appreciate how much selection bias is in everything we do. When they hit the button, you're like, oh God, please give me sutures, or oh God, I don't want sutures. I think it's so important to talk about.
I also think it's important to talk about it because this forum is like Mike's confessional.
No, that's Eminem. That's Eminem.
Well, okay. I'll tell you what. Ajita, can you stop sharing for a second? Let's go ahead and see everyone's faces.
Maybe.
Are we stuck? We have to watch your screen the rest of the evening.
I don't know how to unshare.
Someone had a comment?
Yeah, I was, it's Randy.
Hey, Randy.
On call, so I didn't see the first 40 minutes of the presentation. I started with Ajita's, but I know Mike and Ajita and I have talked about this multiple times before, but it's funny to listen to Mike, who's so caught on fixation, whereas, in the first half of this century, I was fixating based on reeves and doing open reeves, and I was a true disciple to the French technique with 10 or 12 transfascials. And then it just, the patients get bigger, it gets more onerous. So you start doing less and less. And then you think, well, can I do it 2 on each side? But then it starts tenting. And then then you got to do at least like 3 on each side. And then it's still more work. And then patients are complaining of pain. So then I stopped doing it in the reeves. And then we started doing more TARs. And now you've got, instead of 7 centimeters of mesh on either side of the midline defect, you've got essentially 15 centimeters of mesh on both sides. And if it worked okay without transfascials on the 15 centimeter retrorectus strip, it really should work for a 30 centimeter. So it's interesting, and I'm excited you guys are getting the trial underway and getting these numbers. But I mean, other than mesh fracturing, I think my recurrence risk is pretty low, and I haven't put very many transfascials in the past, say, 10 to almost 15 years. Even the ones, if you go back to the central tendon, I think the M1s are fine. I think the M5 suprapubics in a greater than 37, 40 BMI patient, especially it seems like some of the females, the way the retroperitoneal fat pushes up, I've noticed that if you don't put stitches in Cooper, sometimes the mesh wants to get pushed out of the retropubic space. So those I definitely will do fixation for there, but as far as the lateral semilunar stuff, unless it's a peculiar left lower quadrant hernia from a stomacide or something, I don't routinely do it. So I'm very excited to see how the actual data comes out and either supports or refutes my bias.
Just for the record, I am not as closed-minded as you might think. I have been fascinated by this trial. And I am certainly, we don't know what the data is yet, so we'll have to see. But I mean, I think it's, we do, just for one other thing to add to this, we have a data safety monitoring board. We review the patients, every 100 patients, just to make sure that we're not having critical failures and those type of things. So again, I think that, to me, what this trial really is kind of the right story of the sequence of how you're supposed to look at something. You start with retrospective data from registry, you power up a trial, and then you put it to a randomized control trial, then you make the change and you follow it long term. So I think the reality is we just don't know, but I think it is much more compelling. Randy, I might comment, I think this is one thing, and Ajita mentioned this, but I just can't stress it enough. My biggest concern with whatever this trial shows is that, and I felt this way before the trial, that we are over treating hernias routinely now in ways that we never did before, and that we are carpeting people with mesh and putting these enormous pieces of mesh. And there's no doubt, when this is my patient and I'm worried about an M1 or an M5, the dissection that I do, I worry how reproducible that is, to be honest. And so I think this has to be taken, whatever the results are, with a bit of a grain of salt. With us on this call and the people who are here at night are super engaged in hernia surgery. If you stop putting sutures in the masses, we don't really know what that will be yet. I think that just ought to be mentioned.
So
well,
I'm
I
just
think
curious.
you're 100% right about that. No, sorry, Ben. I agree. I think you're probably the first to come to the realization. Some of us are, a bit behind you, but what I do in my daily practice and what my residents see isn't what most of them are going to go out and practice at all. And we have to, not everybody can do a TAR correctly. And in fact, a lot of people can hurt people doing it. So I think we all have to be good stewards of these things.
I mean, the reality is sutures might not be the thing that saves you. I will concede that, but as we take away stuff and as we're kind of like over treating things, I think we just have to kind of step back and say, what is right. I mean, I don't know the answer. Our trial is not going to answer that question. That's just life. You got to follow these people and see.
Well, but I do think that there is some value in the idea that, there is without question a movement towards not routinely placing transfascial sutures. And to a large extent, that's been done without any real supporting objective evidence. So despite the fact that we are likely to find that there was some selection bias in our study and that perhaps, all of our endpoints aren't perfectly defined or whatever it is, whatever our limitations are going to be, I still think it's a relevant question because practice has already shifted towards that and we don't understand the consequences of that move. So I think perhaps putting a little bit of objective information behind that may be valuable to some people.
Well, I think, Ajita, I'll say one more thing and then I'll shut up for the night. But on that vein of thought, you say it shifted, but it has shifted because just today I did an ETAP Reeves. My ETAP is essentially a retromuscular Reeves from basically sternum to pubis. So that's and this lady, she's obese. So that was a 20 by 35 centimeter piece of mesh. And there's absolutely no transfascial fixation. So when we talk about people not fixating, well, we now have a new technology and where we routinely don't train to fixate. Based on my open experience, I wouldn't fixate anyway, but that mesh is just held in that space. Sometimes I'll fixate with 4 interrupted vicryls just to make sure it doesn't roll up during evacuation of pneumo. But there's lots of questions that are being generated.
Yeah, and I think
Yep,
that brings up
I
one of the
agree.
most important points of, especially those of you on this who do the majority of your retromuscular repairs in a minimally invasive way, specifically robotically. I'm just kind of curious if you guys want to unmute yourself and are willing to kind of share. Do you fixate? Do you not fixate when you're doing this robotically? I mean, I'm guessing you probably don't. And if you do a lot of open repairs, do you also fixate or not fixate? Tell you
Are
what.
you talking to me?
What's that? I was gonna say, let's. Yeah, Ajita, why don't you take that?
Gina, you do both. You do robotic and a
Yeah.
lot of open. What do you do?
Yeah. Well, so for my robotic ETAPs, I do not fixate, and for my open, I randomize.
So I mean, this brings up the point, right? Because I think that's the pattern we've seen. In fact, when I'm speaking to my colleagues who do primarily robotic retromuscular repairs, like, what are you talking about? Of course you don't fixate anything. I mean, it's almost like a given. Like, why are we even having this discussion? And the reason why is, of course, because how we trained was largely with fixation for all of our open retromuscular repairs. So there's this huge disconnect.
There is a disconnect, but I'm not really sure that our study can necessarily be used to answer that question either, because when we're not opening the midline, just fundamentally, there's a pretty big technical difference in the operation, even if we sew the midline closed robotically. So I don't actually know that this study could be used to extrapolate to that finding reasonably.
Yeah, I mean, I think, listen, robotic retromuscular hernia repair is in its infancy, aside from, a couple studies done by fairly high volume surgeons. What's really happening in the real world and the outcomes and everything are unknown. And, to Randy's point, I mean, I don't know how big the hernia you were dealing with today, but the truth is we don't know yet. Do you really always have to go from the xiphoid to pubis? Are you going to get hernias when you stop 5 centimeters? I think, like, to me, all of these things are great questions that we need to apply science to and through the registry, and kind of take it through this process again, where you look at the registry, you do a retrospective study, you kind of come to some general conclusion, and then you put that to the test of a randomized trial. I think it's okay to say that we're doing things right now that we're not sure about, because we still have to take care of patients, but just understand that, that may or may not be borne out when you look at it, and particularly if you were able to look at it at a larger group of people across more of a spectrum of the reality of hernia surgery. It's just unknown, and it's okay to not know the answer and still do something. I just think it's important to recognize that, we just don't know. And a lot of things we think we know, when we study them, we figure out we weren't right. And when you think back, why am I doing this? I'm just doing this because the guy I did my fellowship with told me to do it. And so I follow myself. My partner told me to do this. So I think that's the beauty of this, is just endless questions that we should embrace, not ever become defensive about. Hey, real quick, because Clayton asked this question, I'm actually really curious, because we agonize over these things in our lab meeting, is, there is not a lot of minimal clinically important difference data out there in the real world for hernia surgery. So, the 10% number was a controversial choice by us. but you kind of have to set the bar somewhere. So I don't remember if you know what our baseline recurrence rate was.
No, I don't have it. And also I did pull up the trial protocol to see if we had perchance put it in there, but I didn't find it.
I think we used Shervin. I think we used whatever my thought was we used what you guys presented.
Yeah, I think you guys did.
And what was your recurrence rate at 1 year? Do you remember?
For HRI, it was like 15%, something like that.
So we were like 5% on either side, right? Isn't that what we said? The 10% is 5% on either side.
Correct.
Right. So it's basically a 5%. It's a 5% window. Do people think that's okay? Is that too much of a recurrence? Is it because the way you set these things up has a lot to do with how many patients you need and whether you find a clinically relevant difference or not.
Also, just to add that, part of our discussion about these trial designs, particularly non-inferiority trial design, is that when you set it up, not only do you have to determine that kind of bracket on either side, so you have to say your null hypothesis is that no fixation is not different than fixation by greater than 5% on either side, so 10% total of bracket, and all of that has to be explicitly stated up front. And then in order to determine that something is non-inferior, you have to be able to reject your null hypothesis, which is a little much to kind of work through, but that's how these trials are set up. So for us, we did agonize to get to that 10%, but I also agree. I'm curious to know, does anybody have a different kind of window for what the minimally important clinical difference would be, at which point you would not be willing to do no fixation?
Yeah, and this is key because that again sounds like a lot of statistical stuff that you threw at us, Ajita. But that question is not that question is actually not a statistical question. It's a clinical, what's important to us kind of thing. Yep, that's exactly right.
Well, so Ben,
the reason I brought it.
Go ahead, Clayton. Go ahead.
I actually, funny. You guys had all these debates when I was gone. It was between when I was right before I started, between fellowship and when I got going. And when I came back, I remember going through, okay, yeah, that makes sense. And then you're like, yeah, 10%. I remember thinking, ooh, that's a lot. Like, and like I missed the whole like debate and everything. But you guys had already kind of like come to the conclusion. And I remember thinking, ooh, like that 10% is, that's like, so if it's 8 or 9, we're like just gonna stop fixating because 8 or 9% recurrences, or like it's gonna be okay, I guess. So,
well, that's the question I'm going to ask Ben. Ben, if this study ultimately shows substantially less pain at 30 days and in the early post-op period, a 1-day difference in length of stay, how much more recurrence will you accept to get to that great short-term data that verifies your poorly designed retrospective trial?
Oh my God! I'm not gonna follow this trip, dude. I've known you. This is like too long a relationship for me to fall into that trap. So, actually, the 10%, Ajita, when I looked at your numbers for a non-inferiority trial, that's not a lot of numbers. That's not a lot of N for a classic non-inferiority trial because of the 10%. So most of them randomize upwards of 200, 250, 300 for much tighter differences, kind of like what Clayton's getting at. More along the 5% type of range, where it's probably just kind of looking at your numbers, it's going to put you at about 200 per arm or something like that. So, 10% is kind of big for a non-inferiority trial.
Is there a statistical out for that? So, like, if it's, can we keep going? Like, can we just be like, okay, let's just keep going and find out if it's whatever it is. If it's 7%. And we're done. Can you redo something and be like, okay, let's just keep going and see?
Nope. That's part of the fun, is that it's all pre-specified, and beyond that, any additional kind of either exploratory analysis, post hoc analysis, any of that will only ever be considered hypothesis generating, but cannot be used to claim, any kind of broad statement about your findings.
I mean, you could have if you set it up that way, but you can't.
Let's take the boring Cleveland Clinic statistical discussion, and you guys can continue that somewhere in Cleveland.
It's the only thing we don't know. We don't know how to do this. We're asking for help.
Who would ever thought I would have to say that?
We operate, dude. We don't know how to design this crap. We just operate.
Smoke and mirrors, smoke and mirrors. All right, let's go to the chat. There's a couple of themes that came up in the chat I think are important. Number one is, it seems like a lot of folks who do ETAPs don't fixate, but when they do opens, they do fixate. Again, kind of that tension we've been talking about there. Andrew Schneider said that he does laparoscopic ETAPs, does not fixate, and open rectorectus do not fixate. And certainly struggle if I should use drains or not. We talked a little bit about that earlier. The drain discussion I think is fascinating. And again, it's one of those things that we either have a way or don't weigh. And of course, I said, yeah, I use drains for everything, except sometimes when I do a Reeves and it's not a huge dissection. Sometimes I won't use a drain. Sometimes I'll use fibrin glue in that to replace a drain, with the idea that you don't want a lot of fluid building up there. So here we go. We're going completely opposite, Mike.
I mean, my God. Well, listen, the one thing I think that is fascinating, and again, I mean, I think you always have to be careful, critical, not that it's bad, but when you do a minimally invasive technique, whether it's lap or open, and then you get away from basic open principles because it's harder to do minimally invasively, you should always just look at that with concern, I think, and caution, and understand that the reality is when you look at the QC, our passive follow-up is low. It's like 20%. So all these things that everybody's doing, we really don't know the long-term effects of those because it's really hard to follow these people up. So I just think, when we all do these things, until you follow it up and you're like, wow, it's not as great as I thought, we just don't know. And that's the one thing I think the QC should really make clear to everybody is long-term follow-up is really, really challenging. And it's okay that it's challenging and we're working to make it better, but we just have to accept that many of our stances on things, we just don't know because long-term, we know. And the other thing, the ETAP thing, you have to be careful about all of that because a lot of this, we don't have a great staging system. And so the reality is if you're doing a small hernia and you're putting a 25 centimeter piece of mesh and you're carpeting people's abdomen, you don't probably need sutures, and you should question maybe if that's over treating the hernia open or robotically. So I think all of this kind of has to be weighed in, and this is where like the selection bias of a lot of this retrospective stuff is just hard to figure out. And same thing for drains. If you're doing small hernias and putting small pieces of mesh, you probably don't need a drain. I think that's okay. But if you're using the whole retromuscular space and you don't put drains, that's a little bit of a different thing. So the kind of I put drains or I don't put drains, you got to narrow it down. It's talking about. I think that's an important take-home message of there's a lot of kind of art to this and not science, and you can't be steadfast on anything.
Well, I think that's an important point, and I would say that, like at least in my own practice, I'm not doing an ETAP on anybody with a hernia greater than about 7 centimeters in greatest width. That is a different patient than the one that I'm doing an open retromuscular abdominal wall reconstruction on in my practice, and largely in all of our practices at the clinic, primarily because the majority of those smaller hernias do get sent off to do robotic trials or whatever else it is. So it's not the actual same hernia disease either in my mind. So that's the other reason that I'm not sure I would extrapolate the two or consider them to be the same.
Yeah, and I think one of the differences that we're all talking about kind of in drains, no drains, glue, no glue. If you follow your patients and you look at your own data, you can kind of fine tune your practice based on your own data. That's the whole glory of the QC on the very local level. I mean, we're talking about randomized trials with a ton of patients, ton of different institutions. But you can look at in your own hands, your own patient population, what changes to your practice can do, either positive or negative. And I think that's one of the beauties of following your patients in the QC. Couple of wrap up things. So first of all, I think this is a fantastic discussion. I think it's a really, really great example of a real clinical problem everybody has in their minds. And this transcends, whether you do robotic repairs, laparoscopic ETAPs, or open repairs. This is a really salient discussion, and the ability to take information that's collected in the QC, design a non-inferiority randomized trial. We're really looking forward to see what those results are in a couple of short years here. Couple of other opportunities for any of the residents and fellows on the call, or those of you who have residents fellows. The QC resident and fellow research grant deadline is upcoming, I believe in May 1st. I posted the link on the chat where you can get more information about that. And also for our trainees, residents, fellows, please join our resident fellow committee for the QC. It's a growing committee. It's a vibrant group, and we're getting a lot of traction with our resident and fellow committee membership. So any other final thoughts, wrap up comments from our panelists or our discussants? If not, it was a great discussion, folks. And I think it shows really the power of this type of collaboration. Check the website for the next QC Core Insights. And I want to thank all the presenters, the discussants, and kind of a really robust discussion we've all had about this topic. And again, thanks a lot for your attention, and have a good night. See you at the next QC Core Insights. Thank you.
Thanks, everybody. Have a great night.
Thank you.